Hello everyone, this is your instructor Kwame Shen. This lecture is part one of a two-part lecture on microbial infections of the skin. The objectives of this lecture is to have a better appreciation of the anatomy of the skin, briefly, ways by which microorganisms access the skin and cause diseases, the role of normal microbiota in terms of protecting the skin from infections and sometimes causing infections. So in that context, we'll look at staph and strep skin infections, staph aureus mainly, and strep epidermidis, and then other infections of the skin that are viral in origin that may have to do with the physiology and anatomy and the exposure that we get based on the environment that we are in. So in that context, we'll look at chickenpox and smallpox and measles and examples of such nature. We'll also look at infections of the skin that are caused by fungi. And in that regard, we'll look at candidiasis, scabies, and pediculosis. Now, for all these organisms that are causative agents, we'll look at how they're transmitted, the signs and symptoms, and how they're treated or managed. So the structure of the skin is, broadly speaking, in terms of layers, you have three layers. You have the epidermis, you have the dermis, and then the fat layer or subcutaneous layer. The epidermis is made up of dead tissues, and these are tightly packed cells, epithelial cells, and they contain the protein keratin. And one of the important characteristics is that they have a waterproof nature. So they prevent a lot of organisms from accessing the skin, very tightly packed tissues that we have there. And it serves it serves in terms of the physical function to be a very important barrier to microorganisms in terms of them having access to the deeper tissues of our bodies. Then there's the dermis, which is a bit thicker. It's made up of connective tissues, and these are living tissues. So it is in the dermis that you have the origin of hair follicles and sweat glands and sebaceous glands and the likes. And it's well innervated with blood vessels as well. So the skin has an important physical barrier, but then there is also the chemical component of it. There's a chemical barrier, and we touched on some of these when we're talking about the immune system. So perspiration or sweating, when we sweat, in terms of homeostasis, we are trying to bring down the temperature. But in addition to that, the sweat serves other functions. It's made up of a high concentration of salt, which would inhibit the growth of a number of microorganisms that are potentially pathogenic. In addition to that, they have lytic enzymes in them and some antimicrobial peptides that also inhibits the growth of other organisms. And then we also have the oils that are produced by our skin, the sebum, from the oil glands. So you see these glands here. And these contain lipids that also tend to inhibit the growth of other organisms. It has some proteins in them and some salts that would also prevent the skin from drying and keeps them moist. But the same environment that prevents the growth of other organisms that are potentially pathogenic also serve as a very conducive environment for many microorganisms. So it's a two-way thing. It gives protection, inhibits the growth of others, but in the same way, it's end up creating the right environment for others. So if we look at the normal skin microbes, These are generally gram-positive microorganisms, such as staphylococci, micrococci, that tend to thrive in environments that are dry generally and have high concentrations of salts. So in addition to staphylococci and micrococci, you also have the diphtheroids, which also produce acidic end products, and that keeps the pH of the skin in an acidic range from 3 to 5. So that also serves as an inhibitory environment for a number of microorganisms that would prefer a more acidic or neutral pH. So you have some areas of the bodies that you see a high concentration of the skin microbes, and you mainly see them in areas where there's a lot more moisture, sebum, and you tend to have them in the armpits and in between the legs and areas like that are hidden and not directly exposed to the environment. And it's in those areas where these microorganisms are able to metabolize the oils and the proteins that are on the surface of the skin and will end up producing some form of body odor. Now, it's important that we understand, as we talk about the skin, we understand certain terminologies in terms of presentations of symptoms and their descriptions. A very commonly associated symptoms with a number of skin infections are rashes and lesions. And a lesion is a single area of altered skin, and it may be solitary or multiple. A rash, however, is a widespread eruption of lesions. And so if we look at, for instance, the types of lesions that we do have, you have those that are described as vesicles, that are small fluid-filled lesions. So this is a vesicle. You see the fluid there. It's very limited in terms of the area that it covers, just about 1 centimeter. There is no pus associated with it, and it's limited to just the epidermis, as you can see. Then you have bullae. These are larger fluid-filled lesions. So it's more than 1 centimeter. It covers a wider range, right? And it's also basically limited to the epidermis as well. Then you have the macules, and these are flat. They are often reddish, and so not as raised as you in terms of being fluid filled as you will find in the vesicles and the bullae. And it's also limited to just about 1 centimeter. Then you have the papules. The papules are characterized by pus. So as you can see, and it's typically, as you can see, it's not limited to just the epidermis. You have some of it in the dermis. Okay, but in terms of the area, it's roughly around 1 centimeter as well. There may be a few variations here and there. And then rashes, you have exanthem rashes and enanthem rashes. Exanthem rashes are rashes that are caused by disease conditions on the skin, and then enanthem rashes are rashes that are on the mucous membrane. So you're talking about rashes that you see in the interior of the mouth as associated with foot and mouth disease. Staphylococcus epidermidis is an important pathogen when it comes to the skin. They are part of the normal microbiota, and they constitute about 90% of the normal microbiota. And so these are coagulase negative strains, so they don't clot or agglutinate blood proteins, plasma proteins. as compared to Staph aureus. But they become pathogenic when there is a break in the skin or through some surgical procedures, and they're able to have access to the sterile parts of the body, which hitherto they don't have access to. They are mainly associated with the hospital or healthcare infections because they formed biofilms and associated with catheters and other invasive procedures that are administered in the hospitals. And generally, there is increased resistance to desiccation and disinfectants. And it's mainly because they form biofilms. So when they form these biofilms, they are difficult to treat and manage. Another important normal microbiota, which is a potential pathogen of the skin, is Staphylococcus aureus. So these form golden yellow colonies. Most of them are pathogenic, but they are permanent nasal microbiota that we find in about 20% of the population. And you may occasionally find about 60% carrying them. So you may find them on the skin. You find a lot of them more in the nasal passages as well. But most of the pathogenic, not all the Staph aureus strains are pathogenic, but the pathogenic strains are generally coagulase positive. They have been found to be generally resistant to treatment. So you have a lot of resistant strains, especially in the hospitals and in the communities as well. So we have methicillin-resistant Staph aureus, which is one of the difficult strains that we continue to grapple with in the healthcare system. So infections that are caused by Staph aureus are several. Staph aureus may cause folliculitis. Folliculitis is when you have pimples. And when Staph aureus is transmitted from normal passages, and they're able to have access to the hair follicles. So the openings in the hair follicles, once they're able to access it, that's when they cause pimples. And as you can see in this inserts here, and the pimples are generally more tiny. They however, can progress based on how they are managed. Some people tend to press them and force them and handle them in certain ways that causes the movement of the Staph aureus to other areas of the skin, and that may exacerbate it. And then you have the furuncles, which are boils. So these are furuncles, and they are a bit more serious than the folliculitis. It results in pus, the accumulation of pus, and there is abscess. And then there is carbuncle. So that's an example of a carbuncle, characterized by redness. So there is a deep round red tissue. It's harder compared to boils, but it's deeper as well, and it's typically will progress from a furuncle or a boil. Then you have impetigo. Impetigo is generally caused by Staph aureus. It may also be caused by Strep pyogenes. It's highly contagious skin infection, mostly found in children between 2 and 5 year olds. And so you typically will find them in children who attend kindergarten. And because it's highly contagious, if there's an outbreak, there is one person or two people having it, it's very easy for it to spread amongst all the kids in the care center. There are mainly two types of impetigo. So you have the non-bullous impetigo. Remember, this is in reference to the type of lesions that it forms. So if we say it's bullae, you have these larger fluid-filled lesions, and so you have non-bullous. It means it's not associated with large fluid-filled lesions. So it's non-bullous impetigo. It's the most common form. The pathogens will break through the skin. So you're talking about Staphylococcus aureus, and then it spread to surrounding skin tissue. So there is a form of autoinoculation where one lesion breaks open and the fluid spreads to other parts of the skin, and then you end up having the Staph aureus accessing those parts of the skin and causing the lesions there as well. And so this is how typically it will present. And so there is some form of autoinoculation that is taking place. So lesions will rupture and form light-colored crusts. It is these crusts that, when they spread, the fluid in them will contain Staph aureus, the causative organism, and then will end up causing more infections on other parts of the skin. We can use topical antibiotics to treat these, but typically these are self-resolving. So without even treatment, they would resolve by themselves without any scarring. Then you have the bullous impetigo. The bullous impetigos are caused by the Staphylococcus toxins, the exotoxins produced by Staphylococcus aureus. Okay, and these toxins are described as exfoliative. Exfoliative mainly because it causes a separation of some of the skin tissues. And so you have exfoliative toxin A and exfoliative toxin B. Toxin A remains it causes bullous lesions that remain localized, and so it's a very localized form of the impetigo. And then the ones that are caused by the exfoliative toxin B are more widespread and result in scalding of the skin. So we call it the scalding skin syndrome. So it leaves these scars behind once they heal. So the symptoms is that we have toxin, which will cause the separation of the skin layers. That's why it's described as exfoliation. There is frequent outbreaks in hospitals, nurseries, and in those instances, it's described as pemphigus neonatorum. Pemphigus neonatorum. Then you have toxic shock syndrome. You have a shock when there is a drop in the blood pressure, so hypotension. But in this case, it's caused by toxin. The toxin that are produced, the toxic shock syndrome toxin 1 produced by Staphylococcus. So initially, it was associated with the use of vaginal tampons that were left in place for too long, and it's ended up becoming contaminated, and then you have the Staph aureus producing the toxins, and it produced this toxic shock syndrome. However, more recent, because tampons are not that commonly in use as before, the more common forms of the infections that we see are non-menstrual forms of the toxic shock syndrome, which is caused by the use of absorbent packing in nasal surgeries. So these are shocks that result from people undergoing nasal surgeries because of the absorbent packing that is used to reduce the loss of blood. And then also in women who have just labored. The symptoms include vomiting, fever, scalded skin syndrome, as you can see here, and sometimes it may result in organ failure, especially if there is a shock associated with it. Then there is erysopelas, which is also caused by strep pyogenes or group A streptococci, generally called GAS, and they are some of the most important disease agents in humans. They produced streptolysins, streptokinases, hyaluronidase, and deoxyribonucleases. So these are all enzymes, and their name suggests or indicates what they do. And so deoxyribonucleases will break down nucleic acid, DNA. And the symptoms that are associated with them will be lesions of erysopelas. So that's the lesion of erysopelas, as you can see here. And caused by group A beta hemolytic streptococci toxins. It may result in local tissue destruction, sepsis, sore throats, and sometimes fever. The beta lactams are very effective in treating these. And a good example would be cephalosporin. Penicillin is also a beta lactam, but a lot of these microorganisms have grown resistance to penicillin. Then there is a necrotizing fasciitis. Fasciitis is an inflammation of the fascia. The fascia is a connective tissue that surrounds muscles and blood vessels and nerves. And so these are also infections that are caused by group A streptococcus, or GAS. It results when there is a minor break in the skin, which causes the introduction of these pathogens, which hitherto are normal microbiota, into sterile regions of the body, tissues. And generally, early symptoms are not recognized, but once the pathogen establishes itself and continues to replicate, you have rapid destruction of tissues, systemic toxicity. That may result in about 40% mortality in patients. If it's associated with toxic shock syndrome, then it will result in about 80% mortality. Okay. And the immune system also plays a role. So it's a component of autoimmune disease relating to these infections with streptococcus pyogenes. And that is when you have superantigens that are present in the pyrogenic toxins of streptococcal M proteins, which they use in attaching. And these superantigens would then cause the immune system to react in a hyper-sensitive manner as well. Treatment is generally done using broad-spectrum antibiotics. Then you have Pseudomonas infections. So these are caused by Pseudomonas, example Pseudomonas aeruginosa. The symptoms are self-limiting. So if you take Pseudomonas infections that results in Pseudomonas dermatitis, it is self-limiting. So it resolves itself in about 2 weeks. It just goes away. The rash goes away. It's associated with swimming pools and hot tubs that are shared. Then you have otitis externa, or swimmer's ear, which is also frequently caused by Pseudomonas. It's associated with painful infection of the ear, which external ear, and then it's going to spread into the internal ear. And it's often common in people who swim a lot. Pseudomonas aeruginosa, which is an important member of the group of Pseudomonas that cause skin infections, is an important hospital-acquired infection. It's very opportunistic and very common in burn patients, and it's very difficult to treat as well because it forms bioforms. And whenever microorganisms form bioforms, they are more difficult to treat because they are resistant to desiccation and disinfectant as well. Important drugs that are used to treat them are quinolines and the beta lactams as well. Then you have the Beryllium ulcer. Beryllium ulcer is caused by Mycobacterium ulcerans. Early symptoms are almost non-existent, And so it's very difficult to detect early until you have the deep ulcer developing. That's an example of the ulcer-associated Beryllium ulcer. So you have the deep ulcer. There is it could lead to massive tissue damage, which may require amputation. And it's caused by the microorganism Mycobacterium ulcerans. So that's where the name comes from. And this microorganism produces a toxin. A toxin is known as mycolactone. And it's the mycolactone toxin that causes the tissue damage. It's very common in swampy areas or slow-flowing waters. And it's diagnosed typically by the appearance of the ulcer. Treatment is by antimicrobial drugs such as streptomycin and rifampicin combinations. So there is a synergistic application there that using the two together gives a better result than using either one of them separately. Then you have acne. Acne are common skin diseases that you find in several people. About 70 million people in the US have it. More commonly in teenagers than older people. And it's caused by clogged follicles. So the hair follicles become clogged, and what happens then is that you have far greater skin cells that are shed inside the follicles than normal. And when this is combined with the sebum, or the oils that are produced by the sebaceous gland, then it causes the acne. And so based on the types in terms of how they are formed, you have the comedonal or mild acne, you have the moderate, and then you have the severe. The comedonal or mild is caused by the accumulation of sebum. So you see, typically you see white heads, comedos. So these are the white heads. So the acne appears whitish. But it would eventually break through. There will be a protrusion, break through, and once the pus, the fluid or sebum exits, you end up with blackheads. And we can use topical agents such as azelaic acid or salicylic acid preparations to treat it. Then you have the inflammatory acne, which is moderate, and is caused by the action of the bacteria such as Cutibacterium acnes. What it does is it metabolizes this sebum that accumulates within the acne, and then it produces fatty acids, which then results in an inflammatory response. So the immune system is triggered, it causes an inflammation, and it results in pustules or papules. So there's a pus formation there. Benzoyl peroxide is very effective in treating it. And more recently, laser light treatments have been employed as well. Then there is the nodular cystic acne, which are severe. They are formed from the progression of mild and moderate ones. So when you have a mild or moderate acne and it progresses, it exacerbates, you end up having the nodules or cyst forming, becoming inflamed. And once you have the nodules and the cyst forming, then it's really severe in that case. And isotretinoin is effective in treating them. And so the last infection of the skin that we will look at for the first part of this lecture, the warts and the papillomas that are caused by papillomavirus, generally benign. There are forms of it that become cancerous. So you have the genital wart, which is a common form of STI, which is caused by the papillomavirus. And appearance of warts after several weeks of incubation is a classic symptom. Treatment would be the use of cryotherapy using cold nitrogen, and electrical currents have also been used as well. And so this brings us to the end of the first part of our lecture on infections of the skin.